All right, just a quick clarification from the last video before I finish up the fourth of Skeletal and get these posted today. I don't expect you, and I might have mentioned this, I just want to make sure I did. I don't expect you to know parathyroid hormone or calcitonin or calcitrol as far as their structure goes. I put those up there, I put the images up just so you could see and put a face with a name. What I want you to be able to do is tell me, what do they do? And to apply that and say, okay, how do they impact things like osteoblasts and osteoclasts? I think you'll be able to figure that out pretty clearly as long as you know the function. So we had finished up the last video right back here on fracture repair and how to do it with our hematoma, and then our hematoma becomes this callus that is essentially cartilage. The cartilage is then replaced by a bony callus as the osteoblasts get to work, and then we have to go through remodeling. So from here, what I want to talk about is if we're going to build a skeletal system, we have to figure out, well, what happens when these bones come together? What happens when we have what are called articulations? I warned you at the end of the last video that we just ran, there are a lot of funky words in here. So I've tried to organize it in a way that I hope makes sense. This is, to be honest, one of those areas with these terms and these words, they don't gel with me. I have really a very difficult time with them, remembering what they mean. It takes a lot of practice for me. I will point some of these things out, like amphiarthrosis, what that means to me as we go through, but these aren't the only weird words of diarthrosis and amphiarthrosis and synarthrosis that you're going to come across and essentially experience today. Also, as far as spelling goes, the Latin, if there is an SES, it's plural. SIS, it's singular. I'm not going to be very picky about that. So if you're talking about plural diarthroses and you jot down diarthrosis, I'll give you a pass. I don't think that matters. So essentially it comes down to this, with these weird words, how much movement is there between the two bones? If you are diarthrotic, there's a lot. I'm getting ahead of the game, but something like your elbow, your shoulder, your hip. The other end of this spectrum, synarthrosis or synarthrosis. I'm also going to do this. I'm going to screw up the pronunciation on these, so please work with me. Have little and in some cases no movement between them. They're literally locked in. We just talked about in the last two videos some of them, so you might be able to see where we're going with this. And then amphiarthrosis. Some. Well, a little is some, so it gets a little bit subjective here. Now here's what I think about when I see amphiarthrosis or an amphiarthrotic articulation. It's between a lot and none. It's kind of a little of both. If you think about the origin of the word amphibian, an amphibian like a frog is going to live part of the time aquatically, part of the time as a terrestrial organism. So it's a little of both. The amphi is a little of both, falls right into the middle. So yeah, it's going to be subjective, but I'm not going to try and split hairs if I give you some weird articulation and say which one of these is it. So what I'm going to do on the next slide, or next series of slides, is show you some actual types with the weird names. Then I'll show you, as far as the movement goes, what of these weird terms terms applies to it. And what are some examples of these? So as I said a minute ago, I've tried to make this as organized in my disorganized mind as I possibly can. Essentially, we have 4 different categories. We might have 1 type in there, 2 types in there, 3 types in there, but hopefully this is going to help out. So no more beating around the bush. Let's look at the first group, the first type. What are called fibrous? Now, a fibrous articulation, you can see it's synarthrotic, so we have very little to no movement. And one of the examples that I pulled for you are skulls, the sutures. The sutures now, these little areas that you see, we all have them, are held together by incredibly short cartilagen fibers. At a younger age, these sutures had a ton of cartilage in here when, especially, you were born. Your head has to be pliable. If you're going to attempt to be birthed, as you all were, and it's done vaginally, not with a C-section or something, you have to be able to fit through mom's pelvic opening. We have big brains, we have big heads relative to the size of our bodies. So that can make it difficult for mom. So between that and other reasons, mom or potentially you may have to undergo a C-section. But these sutures, they don't have a whole lot of movement. Don't try really hard to move around those cranial bones, because they don't really want to move because they're synarthrotic, super short fibers between them. Now, syndesmosis. The syndesmosis is synarthrotic or amphiarthrotic. See what I'm talking about with these terms? It gets, for me, a little tongue-tie-ish. We have longer collagen fibers between the two, which kind of would imply that maybe we do have a little bit more movement. Maybe we are becoming amphiarthrotic. Here's an example that I pulled. It's a real simple example. Between the tibia and the fibula, there's a whole series, this is your lower leg, there's a whole run of what are called interosseous, or between the bone membranes. So we're looking at slightly longer fibers, so there's a little bit of movement in there, or they may be. Same thing with ligaments. Ligaments tend to be synarthrotic or amphiarthrotic, so they fall into the category of syndesmosis. One more of fibrous type articulations, and these I've never really thought about. They're gomphoses. And see, here's what I've just done. I've gone from a singular to a plural when I put this together. These are incredibly short fibers. They are ideally synarthrotic. You might be able to get a tiny bit, a very tiny bit of movement out of them. Here's the one that I think is the best example, a periodontal ligament. And some of you might go, oh, periodontal, it's teeth. Yeah, it is. Here's a tooth. The image that I took off the web was upside down relative to this. I wanted to put it right side up, which is why some of these letters are upside down. Here's a tooth. Here we have a small cavity inside the tooth that's normal. Our roots go up into there. And if you look right down between the tooth and the bone of your either maxilla or your mandible, did that the wrong way around, your mandible, your lower jaw, or your maxilla, your upper, you can't just stick a tooth in there and hope it stays. So what you have to have is a periodontal ligament. Something that maybe you have experienced in the past, I hope not, but maybe you have. If you have ever had a tooth pulled, your dentist will get a hold of it and she'll start to wiggle that around. my dentist is a woman, so yours might be a guy, I don't know. Your dentist, either way, starts to move those around a little bit. And then at some point, out it comes, and you can kind of hear a tearing noise. What's tearing is the periodontal ligament. Also, if you had teeth fall out at a very young age, which you should have, you say, Mom, Dad, I have one tooth that is really, really loose, and why is it staying in there? Oh, it's a gomphosis, honey. It's a periodontal ligament, and you probably wouldn't know what any of that meant at the time. So 3 fibers, it's all about how long the fibers are and how much movement does it give us where those bones come together. Those are the things that we're going to be looking at with these. Now, fibrous, let's jump to a bony type. We just talked about this in the previous video, one of the last 2 previous videos. No fibers, we're talking about bone on bone, synarthrotic as far as the amount of motion and movement between the two, and the epiphyseal plate. It's right here where the epiphyses and the diaphyses have come together and they have physically fused. Remember, that's different than we see with the sutures. The sutures still have those really tiny collagen fibers between them. Now I took this image from the internet. I like dogs. It happens to be a dog image from a veterinary clinic. And I've left this one over here. Here's that big thick growth plate with all of that cartilage that goes all the way around. Once we get over here, you can see it right here as well. It's gone. Now we're to the point where the growth plate, this is closed. We've got bone on bone, and there should be no motion. This is why let's see if I can put this without sounding wrong. If you hit a 14-year-old playing football and give it a shearing motion with the bone, you've got a much better chance of shearing his or her growth plate than once you're an adult and they've closed, because it's now bone on bone and we should have no movement ideally between the two. 3 fibrous, 1 bony. Let's go to the next one. Cartilaginous. I think that speaks for itself. So we're looking at cartilage that are holding these 2 bones together, and I left this same image on here because it's not an epiphyseal plate. I have to do a formatting change there, but now instead it's a growth plate. That's what we had over here. That's why I left that double image up here. So cartilage between a couple of bones, and like I indicated up here, it does ossify later on, ideally, if everything works out normally. And it's synarthrotic as well. Here's the second one. What's called a symphysis. A symphysis is now where we have fibrocartilage. We go back to different histology. Discs, fibrocartilaginous discs that we see on here. Amphiarthrotic, there is some movement. If you can bend side to side or back and forward, that's amphiarthrotic. Not a huge amount of movement, but enough. I think the best example are intervertebral discs. So we've got our vertebrae, and then in between we have these fibrocartilage discs. The image that I just took this off the web from, here is a normal disc, and then it had some pathology with a bulging disc, herniated disc, degenerative disc. But either way, you can see that there's now distance, there's room between the two, and we can get some movement, which allows us to have the ability to change the position of our spinal cord. It's not one straight, solid, osseous rod. But there's another one that is just important to us, I think, at least to women, when it comes to birthing. And it's this, right down here in the circle. It's called a pubic, for these pubic bones right here and here, symphysis. So a pubic symphysis is where our pubic bones, happens in all of us, will come together. And then we'll have our little fibrocartilage disc right down here through the middle. So right down about here behind my belt buckle. What this does for mom is it allows for movement. It allows for motion of the pelvis and the pubic bones, specifically during birthing. So yeah, when you were born, if you were born vaginally, your head kind of deformed and probably came out a little bit pointy because of these articulations. And your mom also had the ability, purely because you were pushing through the birth canal, if you want to call it that, you had some flexibility to move these apart. One thing that I can see right here that I want to point out that's really clear, there's a big difference between a male pelvis and a female pelvis. So let me go back to finding an organism that was 2.7 million years old, like for example, the famous Lucy. We named her Lucy because we knew she was female. Well, how did we know she was female? We had her pelvis. Males, we have a very tight V-shaped pelvis because I'll never birth anything. But if you're female, you need this much more subtle, almost U-shaped pelvic angle. So that U-shaped pelvic angle, the pubic symphysis in there to allow for some movement around, and of course your baby's flexible head all facilitate birthing a big-brained baby. So 3, then 1, then 2. Here's the one that we're probably most familiar with. And this goes all the way back to when we started talking right in the beginning, if you remember that far back, to body planes, body cavities. And one of the types of cavities that I mentioned were synovial cavities. I said, we'll come across these again. Well, here they are. These are amphiarthrotic, excuse me, or diarthrotic. The ones that most of us think about, that I think about with a synovial cavity, are diarthrotic. Lots of movement, like an elbow, or a knee, or an ankle. Sorry. So what we've got is a synovial joint. You already know that there's articular cartilage on both sides. We've looked at that. I've shown you a number of examples of that. And then we have this capsule around the outside. Now, there are two parts to the capsule. One part to the capsule that comes all the way around here is what's called the fibrous capsule. And it's superficial. It's what we see out here in kind of the thicker blue. That's going to be tough. It's going to give stability. Really, that's essentially its primary job. So the fibrous capsule, or some of the time I've seen it called fibrous membrane, is there for support. Not much. We'll get to a couple other things in a minute. Then, just deep to it in this squiggly line is the synovial membrane. Now, the synovial membrane is deep to it, and what it's going to do is secrete synovial fluid. Now, synovial fluid, if you want to try and imagine what it's like, is if I was to run right across the hall and maybe you have a little thing in your bathroom where you can pump out some like soap, and it's nice and kind of slippery. That's what synovial fluid feels like. It makes sure that this articular cartilage, this hyaline cartilage up here, can smoothly move across the cartilage down here. So our synovial cavity, which is this lighter colored area in here, is maintained by the synovial membrane by secreting this really slippery synovial fluid. Couple things to mention about that. I think one important thing. If if you're older, you may know people, they get up and like, oh, my knees are killing me, and they walk really stiffly, but after 30 seconds or 40 seconds, they're walking just fine. Synovial fluid gets pulled into this articular cartilage, this hyaline cartilage on both sides. So maybe grandma's been sleeping all night, and she just slept for 8 hours, and she gets up and that synovial fluid is all in here and in here. Not much fluid in the cavity. Well, when she gets up and she stands up, grandma pushes this against this, the cartilage against cartilage, and kind of like wringing out a sponge, it now puts the fluid back into the cavity. And before you know it, she can move a lot easier than she did when she got up. Now, two last things with this. This is a very simplified example. You can also see ligaments around the outside on each side with this drawing. But ligaments will hold bone to bone. If you have ever had an injury to one of your knees, you might have torn an ACL or an anterior or a posterior cruciate ligament. What those ligaments do is they will physically hold one bone to the next. It's all about stability. And then, let me see if I can draw this. Especially in something like the shoulder, there are muscles that run all the way across this synovial articulation. So, work with me. Here's a tendon to a muscle, back to a tendon. And you think, well, wait a minute, if this is moving, the muscle is going to get dragged across here and the muscle is going to get irritated. Well, luckily, we have a number of these pads. And these pads are called bursa. Don't know how much room I have on the board. B-U-R-S-A-E. And so what I want to kind of finish up with this is something that you might be able to answer. Once again, it's killing me because I can't ask everybody in here. If your bursa, due to a number of different possible reasons, is now losing fluid, and it's not facilitating the movement of the muscle across the synovial joint, your muscle becomes inflamed and it hurts. It's like, oh man, I've got muscle pain in my shoulder. I don't know what's going on. You go in to see your physician, you go into Orthopedic Associates, and they say, oh, we're gonna have to do some treatment on your bursa because your bursa isn't doing its job. What's the condition that you have? Right, bursitis. So when it comes to things like that, bursitis is a problem with the bursa, which allows for problems with the muscle going across this highly movable synovial joint, or articulation, I should say that. So with that being said, I'm sure that as we continue forward into the skeletal system, or into the muscular system, we're going to come back to this because muscles are primarily about moving these bones. So as we start to move these bones over these synovial type articulations, what can we do? We have extensions, and we have contractions, and we have all sorts of different movements that we can get out of these highly synovial and highly movable articulations. These are my favorite because I feel like they do a lot more than a gomphosis, just holding a tooth in. So with that being said, we have done everything from looking at osteons, and we've been looking at extracellular matrix, cell types. We've been looking at different chemicals that are going to upregulate or downregulate deposition of calcium. We've looked at remodeling. We've looked at fracture healing. We've looked at our these different types of articulations. I think we've done a good job with this. So I think we've pulled off 4 videos for the skeletal system. On this last break I took, I was having some YouTube difficulty, but that's no worry of yours. I hope to get these up before our class would officially begin at 4:30. So with that being said, I also have grades coming to you, but I'll push all that out in some emails, hopefully early tonight or late afternoon. If you have questions, you know what I'm going to say next. Email me or call me.